Honey, can you go down to the ovary and pick up an ovum? Where are your eggs, my dear? Why, they're in your ovary. The oofs, the eggs. Well, the ovum is released from rupturing follicle into the abdominal cavity. It's picked up by the fimbria of the oviduct, snatches them up. So the fimbria pick up the oviduct, and it beats. You know, I always wondered, why don't we have an ovary that's directly attached to the fimbria? Why is that uncertainty in that relationship? It's so interesting, isn't it? You know, well, the failure of it may result in an ectopic pregnancy. Now, the interesting thing is that fertilization occurs in the upper end of the oviduct, the distal third, within a day after the ovulation. In other words, you don't have a long time. It's a wonder that any of us get born with the way that these things have such a short window of opportunity to be alive. It's a wonder any of us even made it here. I like to think it's the uncertainty in the relationship between the fimbria and the egg and the ovary that makes the excitement in all human relationships between partners. Maybe it'll work out, maybe it won't. It's uncertainty. Where are you, my egg? Yes. So sperm gets the capacity to fertilize for really only a short period of time. It takes a day or two to swim up there. So the end result is, why do we have such an expanding population when you realize that you only have fertility for 24 hours or so after you ovulate? And the answer is just luck, I suppose. And for about 48 hours after ovulation, the mucus becomes really large to allow it to swim. And that alkaline environment helps activate and energize the sperm. Fertilization of pregnancy, the sperm is transported from the vagina to the upper ends of the oviduct by contraction. See, one of the things that people don't realize is that the oviduct, the fallopian tubes, have muscle layers in them. They actually have contractile tissue. Isn't that amazing? That's where prostaglandins were first described. Did you know that? Most people don't know that it really is seminal fluid has prostaglandins. It's from the prostate gland to help the sperm go in. Really? Yeah, you see, with the seminal vesicle putting prostaglandins in the ejaculatory fluid, it stimulates the oviduct or fallopian tube to draw the sperm in. Amazing. And it helps it beat inside and move inside, and inside it goes. And it basically is like digoxin for your fallopian tubes. The swimming sperm penetrates. That's why 60% of the physical volume of sperm is ATP, to give it jet fuel and rocket fuel. Low sperm counts, less than 20 million per milliliter of ejaculate, gives you low fertility. You see, these low sperm counts mean that you can't conceive. Did you know sperm count's going down on average in the United States? It is. It used to be 100 million 100 years ago. Now it is only about 60 million, still well above. That's why in infertility evaluations, we don't do anything to evaluate the woman until we're sure that the man is shooting enough. The first step in that fertility analysis is you blame the man. 5 or 7 days after you fertilize, you implant. Now, implant the blastocyst does not mean that you're going to be viable unless you make a trophoblast. Unless you have a trophoblast that makes beta-HCG, you need a trophoblast to come by day 25 to make the beta-HCG. The HCG will now rescue the corpus luteum. Help me, I'm going to expire.
Don't worry, little luteum, I'll save you. Dun, 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 dun.
HCG comes out of my trophoblast and sends you a signal that says, I will rescue you, to continue to making progesterone and estrogen. So on day 14, we ovulate. On day 15, we fertilize. We go for a 5-day honeymoon in the fallopian tube. We implant on day 20. A blastocyst, it's a blast. You see, they're coming back from the honeymoon. It's a blast. And then when it's time to work and make a beginning of a placenta, the trophoblast is the beginning of a placenta. And you need the corpus luteum for the first third of the pregnancy. We need the corpus luteum for the first third of the pregnancy to maintain the progesterone and the estrogen. Because without the corpus luteum, you don't have estrogen and progesterone, and you slough off. So trophoblast makes beta-HCG. HCG continues to stimulate the corpus luteum because it looks like luteinizing hormone. That's why beta-HCG in the urine is present so soon after fertilization. Look at the hormone maintenance of the uterine endometrium. So basically you have a little pituitary LH, which stimulates the luteal cells to make progesterone and estrogen. You implant and makes placental HCG because the trophoblast makes the placental HCG. So trophoblast and placental are kind of interchangeable because the trophoblast becomes the placenta. The trophoblast becomes the placenta. And it needs the placental beta HCG, trophoblast beta HCG, to maintain the corpus luteum, to maintain the progesterone and estrogen until 1/3 of the pregnancy, the placenta's got enough machinery to maintain itself. Now, over on the right-hand side, you will see that LDL there, the progesterone. What has LDL got to do with progesterone? LDL is the movable feast of the body that has the precursors that progesterone is made out of. And progesterone is made out of the cholesterol that's on the LDL, and therefore you have all sources of steroid hormones off the cholesterol on the LDL. Now, in pregnancy, what you do is the fetus's adrenal can be used to supplement mom's sex hormones. That's kind of disgusting, don't you think? Your mother used your adrenal to maintain her sex hormones? Ew! Ew, that's disgusting! My fetus's adrenal had my mother make sex hormone? That's ew! My mother put her, I don't even like it when she calls me. Okay, must just show up at my apartment. Now she's putting her sex hormones through my adrenal. That's disgusting. Mom, get your own hormones. But it's true. You see, that's why it's sulfated. That's why the DHEA has to be sulfated so it can go back and forth across the placenta, and it gets metabolized by the fetus adrenal to androgens. It gets sulfated back into the placenta where we get the scent of a woman, the aroma of the woman in the estrogen. In preparation for implantation, we have a luteal phase, and that pituitary LH stimulates luteal cells to make progesterone and some estrogen. Now, I'm being purposely repetitive because I honestly think that it's a section like this you got to really be thinking 3 to 5 times through. I don't think a genius could get this on the 3rd time through. It's so complicated. The luteal phase is fixed. It lasts for 14 days, and it wears off. The trophoblast makes beta-HCG. It rescues the corpus luteum. It rescues it for the first third of the pregnancy until the placenta is sufficiently developed to not need it. The ovaries are the source of the estrogen, and mostly that form is estradiol. So we fertilize on day 15, we implant on day 20, we make beta-HCG by day 25. And by the 10th day after ovulation, there's enough beta-HCG to rescue that corpus luteum from expiring, and it continues to make progesterone and estrogen. Now the question is going to be, what happens next? We need the beta-HCG for the first 3 months in pregnancy. And after that, you don't need the corpus luteum anymore. By the way, where is the corpus luteum? Is it in your pituitary? Is it in your hypothalamus? Is it in the abdominal cavity? The corpus luteum is in the ovary. The corpus luteum is the post-ovulatory follicle. It is the post-ovulatory follicle. In the early weeks of pregnancy, it maintains it so that you need that corpus luteum to make the progesterone and the estrogen. After that, the HCG levels will start to fade away. Corpus luteum secretion makes 17-hydroxyprogesterone, and the placenta does not. And that's a way also saying, hey, it's a precursor. It's a precursor of the other estrogens that are going to come out. Now, relaxin, what a great name, right? Relaxin. I'm going to name myself that. My name is no longer Conrad. My name is Relaxin Agreeable. Relaxin Agreeable. And secreted by the corpus luteum, and it basically relaxes the pubic symphysis so the baby can get out too later on. And what ends up happening is that these levels start to drop so that in preparation for delivery later, and the loss of the corpus luteum, if you happen to have that happen too early, would damage the pregnancy. Now, this is one of those weird, demented physiologists things where they go, At what stage in the pregnancy can you remove the corpus luteum? It's like, why would I want to remove your corpus luteum? To see when you need it. Oh, that's like saying, cut your brake cables to figure out that I need my brakes? No. So the corpus luteum can be removed after the first third of the pregnancy because by the second trimester, placenta is sufficiently developed to maintain itself. It's kind of like staying on your parents' health care plan till you're 26. Life expectancy is 78. You can stay in your parents' health care plan until you're 26. Your parents are the corpus luteum. You need the corpus luteum to maintain you till you're 26. From the third month to term, the pregnancy term means time to deliver, the placenta begins to secrete enough progesterone and estrogen to maintain itself. Remember, in the second and third trimester, it's not controlled by beta-HCG. The ovaries are removed, can be removed. That's just a way of saying I understand what the dependence is on progesterone and estrogen is that I'm dependent on the corpus luteum for the first third of the pregnancy. It's not saying you'd want to do that. Now, the progesterone secretion by the placenta is limited by the amount of precursor, and precursors come out of LDL. I know we think of LDL as something bad that's going to clog up our heart, but LDL is not particularly something bad. It can be something good. LDL is how you get cholesterol. If you didn't have LDL, you die. See, estrogen secretion involves a transfer of steroids to the fetal adrenal cortex. It gets sulfated, and then the last step is aromatase in the placenta. Now, during mid-pregnancy, the fetal adrenal cortex makes a lot of DHEA. It gets sulfated DHEA sulfate, and these weak androgens don't affect the female fetus because the enzymatic activity in the placenta has to convert it into an estrogen, and this is why it's sulfate. And that's why it's sulfated. It's sulfated so that it can make it across membranes and make it water-soluble. And that's why the rising estrogen level tells you that the placenta and the fetus is doing okay. If you have a woman who has a history of spontaneous abortion, you can use estrogen levels to tell you that the baby is going to survive and it will be fine. A lot of estrogen and progesterone is secreted by the placenta and stimulates a bunch of things. First of all, the uterus gets grow because estrogen's like miracle grow for your uterus. Makes it really big, makes the myometrium enlarge. Estrogen is a direct stimulatory hormone. It's like growth hormone just for your uterus. And it increases the components of everything between the estrogen and progesterone. Between estrogen and progesterone, it makes everything. All of those components, the glands, the stroma, the fat, and the breasts too. Estrogen stimulates prolactin, and the prolactin will also make the glands grow. So what do the hormonal changes happen? Well, prolactin is in favor of lactation. So prolactin is stimulated by estrogen. The estrogen makes prolactin out of the pituitary. The prolactin makes the glands grow inside the breast. It makes the machinery grow. But estrogen also prevents the milk from flowing at the same time. Now, there is a new hormone that is unique to the placenta that is called human placental lactogen. This human chorionic somatomamotropin is a very long and irritating name, which is being replaced with human placental lactogen. Human placental lactogen acts as an anti-insulin for the mother. It acts as an anti-insulin for the mother, so under conditions of starvation, and starvation only, it will preserve the food for the baby. And that's a tremendous competitive survival advantage because it preserves the food for the baby so that the baby will survive. That's why it's similar to growth hormone. So it's not growth hormone in the sense of the growth-forming portion of growth hormone, but the fact that growth hormone is an anti-insulin itself. Growth hormone is an anti-insulin itself, and therefore that's why people with acromegaly end up with diabetes, hypertension, hyperlipidemia, and dying at 50 of congestive failure. So there's very little growth-stimulating effect, but because it's not the IGF portion, it's the anti-insulin portion. These metabolic actions of growth hormone basically turn the mother into a diabetic for those who are vulnerable to it. So when it says a person has gestational diabetes, why is it? Gestational diabetes is caused by human placental lactogen. Now, this is often very hard for students to understand. Why doesn't everybody become diabetic then? Because it's only in people who are genetically susceptible, and especially obese people. You have to be susceptible to it. Not everybody, just people who are already near there. Now, during the second trimester, there's a higher insulin state with peripheral resistance to the metabolic effects of insulin. And this makes it so that the fetus gets the food. You see, if mom has an anti-insulin, it means that the fetus will get food better and will get more fed than the mom. The anti-insulin does not happen if you have abundance. If you have abundance of food, you don't have people fighting over the food. You only have people fighting over the food if there's starvation, right? So urine placental lactogen gets secreted in proportion to the size of the placenta and basically tells you, hey, fetus, hi, placenta, how you doing, how you doing, how you doing? Here's a summary slide showing you that the estrogens are going up through pregnancy. The HCG is maximum in the first trimester. We have human placental lactogen and prolactin going up. The human placental lactogen goes up, but doesn't have much effect unless there's starvation. Prolactin is in direct proportion to you notice the red line of the prolactin, the red line of the estrogens? That's because they're very similar to each other in terms of their secretion times. So the mother has a 50% increase in cardiac output, but dilates the peripheral vessels, so that's why you should not normally have hypertension, because there's a 50% increase in plasma volume because the mother has a higher ADH level than you and I do. The mother has a higher ADH level, so that's why every pregnant woman becomes anemic, because you get an increase in the need for iron. The maximum your duodenum can absorb is only about 3 or 4 milligrams a day, and now the mother needs 4 or 5 milligrams. So this is a big increase in iron, and at the same time, you have an increase in ADH, watering out the iron, extra water. There's a 50% increase in plasma volume. But there is no increase in the total number of red cells to make because you can't make more because you can't absorb as much iron as you need. The blood pressure tends to decline in the first trimester because what you're doing is you're just vasodilating up a little bit. The GFR increases because you're dilating the afferent arteriole, which increases the GFR because you're so juicy. And basically, when this happens because of the increase in GFR, your filtered load of glucose goes up. And your filtered load of glucose can go up so much so that some people can't even reabsorb it all. Your big point to know is this. There's a 50% increase in plasma volume during pregnancy. Why? There's an increased ADH in pregnancy. Why? Because there's a reset of the hypothalamic osmostat in pregnancy. And all that juiciness doesn't raise the blood pressure because you have vasodilation, but it does raise the glomerular filtration rate because you dilate the afferent arteriole. The anterior pituitary enlarges because the growth of those cells, the lactotrophs, what do the lactotrophs make? The lactotrophs make the prolactin because they're lactotrophs. What a great name. They're lactotrophs because I want to galactate. Isn't that great? I want to prolactin with my lactotroph. I'm making all machinery. I'm showing some growth. My pituitary's bigger and my breasts are so large. Oh, I'm giving baby milk and there's no charge. Gonna grow my breasts now. Gonna have the best now. Squeeze my nipples, myoepithelial. Squirt it in the mouth that the little baby squeezes. And he looks very happy. I'm a pleases. He doesn't need to suck because it's a squeezer. He doesn't need to suck because it's suckling. Suckling is not sucking because it's not a vacuum. It's not a vacuum because the baby's not efficient. You think he's a Dyson? You think you're going to suck out that baby? Look at this little baby. It's like a Dyson vacuum cleaner. You get dust caught in the corners. Let's suck it out with the baby. No. The lactotrophs enlarge because of prolactin. Prolactin is stimulated by estrogen. And then what ends up happening is a disease, Sheehan syndrome. This is one of those things that everybody tends to learn about when they're in medical school because it sounds so exciting, doesn't it? You give birth and then your pituitary infarcts. Bad. Now, the posterior pituitary makes extra ADH, but it doesn't need extra cellular growth because remember, the posterior pituitary only stores ADH. It doesn't actually make the ADH, it only stores it. Now, if you actually infarcted, you couldn't lactate so well. But remember, lots of people don't lactate anyway. They just get formula. So it's not like the baby's going to die if you don't have the prolactin. So one of the other things is you can get hypothyroidism, hypocortisolism if you infarct the Sheehan syndrome, because it's a type of panhypopituitarism. Panhypopituitarism. No TSH, no ACTH, and no prolactin. Estrogen increases a number of binding globulins. Estrogen increasing binding globulins, so the total T4 goes up, but the free T4 stays normal. Because the total goes up because it's measuring the binding globulin. The total goes up, but the free T4 stays normal. Hyperthyroidism sometimes does increase a risk of preterm delivery, and hypothyroidism is quite unusual in pregnancy because you just don't get that kind of thyroid abnormality. But most of the time, it's an increase in the binding globulin. The normal free T4, the part of it that's active, stays normal. Estrogen also increases the system of the renin-angiotensin-aldosterone syndrome, and that's part of the reason that you get fluid retention, because you also get an extra aldosterone, which makes you retain water too. And that's mostly because we really want to increase plasma volume when we're pregnant, so we have more fluid to circulate. Near the end of pregnancy, the pubic symphysis become a little more distensible. That's a good thing. It's still no fun. I'm glad I don't have to do this. And it makes the passage of the fetus through the birth canal become easier because you've got to make it relaxed through that birth canal. And that's why you've got relaxin secreted by the ovary promoting these changes. But there is no deficiency disease of relaxin. There is no the excess disease of relaxin, and we don't have therapeutic relaxin. So it is like inhibin, just a one-fact question, which is, do you know that relaxin is secreted by ovaries? It helps relax the pubic symphysis and makes the vagina more flexible so things can come out. Now, in response to elevated estrogens, oxytocin increases. Now, oxytocin receptors in the myometrium is an example of upregulation, both positive feedback and upregulation. The more oxytocin receptors, the more there is. The more oxytocin, the more it contracts. The more contraction, the more oxytocin receptors. And the more oxytocin receptors, the more contraction, more oxytocin receptors, the more contraction, oxytocin, boom! And all of a sudden, we're in college. Parturition is the fancy word for giving birth. Interestingly, we don't know what causes it. Isn't that weird? What actually causes it? Do you know that only 5% of women deliver on their due date? Only 5%. Wow. So the oxytocin comes out of the posterior pituitary, and it doesn't initiate the rhythmic contractions. It doesn't. It can augment them. It makes them more forceful. It makes the uterus contract more. And when the head of the fetus presses on the uterus, it makes more oxytocin, which makes it contract more. And prostaglandins increase the contraction, and oxytocin increases the uterus, and the uterus makes the prostaglandins makes more contraction, the whole positive feedback. But what actually starts the thing, nobody knows. Now, we also know that oxytocin is partly responsible for bonding between a baby and the mother. If you take a baby of a different species and you put oxytocin injections into the mother, even if you put a koala bear next to a cat and you inject the cat with oxytocin, the cat will bond to the koala bear. It actually makes it so that it's a hormone that makes the mother take care of the baby. Isn't that interesting? So let's say that there's somebody you like, but they're not paying attention to you. What you should do is walk up to them when you're nearby and spray oxytocin on them, or give them like oxytocin-flavored chewing gum when you're near, and they'll bond to you. Spontaneous abortion is a term for miscarriage. It's the proper term for miscarriage. The fetus dies, the toxin products originating from the fetus make prostaglandins in the uterus, and it makes the contractions happen and expels the products of conception. And this is part of the reason why we can use a drug called misoprostol to induce abortion in people. So we understood this. Remember what I said before that prostaglandins were originally described in the prostate gland? They help the fetus get expelled if it's dead. They help the fetus get expelled if it's normal by upregulating oxytocin receptors. They help the sperm get into the fallopian tube by increasing the rhythmic contraction of the fallopian tube. And they can help you get rid of a fetus when you want to expel it. That's why misoprostol, which is artificial prostaglandins, can help a spontaneous abortion. The mammary tissue is grown in pregnancy by prolactin. Estrogen makes the pituitary stimulate prolactin. Now, in order to have puberty, you have to have a normal thyroid hormone level. In order to have growth hormone release, you have to have normal thyroid, and then you get the growth spurt. But the mammary tissue, although it may grow with prolactin and estrogen makes the prolactin. Prolactin makes the glands. But the milk synthesis is blocked by the estrogen, so it doesn't let the milk flow, which is a very good thing too, because if the baby's inside you, you don't need the milk flowing out now. You don't want the milk flowing now. The estrogen makes the prolactin. The prolactin makes the gland grow. The gland machinery goes up, but you don't let the milk flow. And that's the same way. You don't want the milk to flow when baby's inside because there's nobody there to drink it. You're at school, you're at work. Would you put out a glass of milk at home now and you're not going to be home for 6 hours? No, it'll spoil. It'll be wasted. So the estrogen prevents the milk from flowing. That's why after delivery, you got to wait for the placenta to come out. You got to wait for the placenta to come out. Then the estrogen level drops. Then milk will flow. Parturition is the $5 word for the baby parting from you. The estrogen level drops because the placenta is removed. The estrogen level drops and then the milk flows. So the glands are there, but the milk does not flow. And when you have a greater level of estrogen, the prolactin receptors may go up, but it doesn't flow until the placenta comes out. That's why on the same day as you deliver, even the suckling won't make the milk flow, because it's like a guy who makes wine. He may be making the bottle, he may be growing the grapes, but he also makes the cork that keeps the wine in the bottle. We don't want it flowing out when there's nobody there to drink it. It's now suckling, which is not sucking like a vacuum, but suckling is a repetitive squeezing of myoepithelial cells is needed to maintain lactation, because if you don't do that, for a couple of days even, the milk will start to dry up. That's why suckling also raises prolactin, and prolactin maintains the gland, and the suckling helps the milk flow and also acts as a contraceptive. Suckling is 95% effective as a contraceptive because suckling inhibits FSH and LH. If you don't have FSH and LH, you can't ovulate. Now this picture says that you have to have myoepithelial cells in the nerves of the breast going up to the brain, into the pituitary, and the oxytocin contracts the myoepithelial cells. That's what the word suckling means. It means it's not a physical mechanical vacuum pressure. It's stimulation based on pressure of the nipple. Prolactin makes the gland grow. Prolactin makes the tubules. Prolactin makes the ducts. But the estrogen prevents it from flowing. Oxytocin causes contraction of the myoepithelial cells. So oxytocin actually makes the milk eject out. Prolactin makes the machinery. Oxytocin ejects. Prolactin makes the ducts. Oxytocin ejects. Prolactin makes the ducts. So if you want to actually stop breastfeeding, you could give a lot of estrogen. It would stop it. This is also why after birth, women have a very big concern about contraception, because I think that if you've had enough babies, you are concerned about, can you breastfeed and still be effective all the way in contraception? And 95% is not good enough, I don't think. So that's why women, if they take an estrogen-based birth control pill, can actually screw up their breastfeeding. So that's why your question will say, why is a progesterone pill better? And the progesterone pill is better, sometimes called the mini pill, because it doesn't interfere with breastfeeding. The progesterone pill is better because it doesn't interfere with breastfeeding. Breastfeeding is about 95% effective, and it should stop ovulation by increasing prolactin. Breastfeeding should stop ovulation. The prolactin should inhibit FSH and LH and stop the ovulation, because if you have a high prolactin, it should stop the LH surge. No LH surge, no ovulation, no baby formed. That's it for the reproductive endocrine section. That's it for endocrinology. This is Conrad Fisher saying everything you're learning matters. It really does. Even when you don't think it does, it does.